I'm so glad you're back home.
Me too. When I got out of the hospital, we went to the drugstore and got a big bag of pills. 12 bottles in all, wasn't it?
And the nurse gave us a nice list with information about all the medicines. But when we got home, I noticed that some of the names on her list didn't match up with the bottles. So I didn't know if we'd been given the right pills or what.
But what it was, the list that the nurse gave us had brand names, and some of the pill bottles had generic names on them. So it was the right pills all along, but how were we supposed to know?
I was in a neck brace for some time, and not being able to breathe the way I should, I developed blood clots on my lungs. I was on blood thinner in the hospital, but they didn't say anything about continuing that when they sent me home. Well, why not?
When they were letting me out of the hospital, I don't know why I remember this so clear. The nurse tells me I gotta take 2 different antibiotic pills. I didn't say anything, but I'm wondering why 2? She never did say anything about why. So I took 1. I figured, what's the difference?
So my wife is being seen by 6 doctors, 2 neurologists, her own doctor she's had all along, a psychiatrist, and 2 more that work with her on rehab. And you'd be amazed at how many times it happens that one doctor starts her on a medication, and when one of the other doctors hears about it, he says to stop taking the medication.
You know, perhaps no area causes greater concern during transitions of care than the issue of medication management. So many factors come into play with medications: side effects, interactions with other medications, patients' understanding and compliance with instructions, to name a few, that healthcare providers must be especially vigilant to ensure medication safety. Accordingly, improving understanding of medications will be the topic of this program. Please note that a viewer's resource guide containing resources such as sample forms and materials accompanies the program as well. Now, let's begin with a look at some of the reasons why medication management can be a challenge.
Many of our patients are seeing many physicians, many providers, each of whom may be prescribing medications that the other providers may not know about. That's why it's so important to have a single list of all the medications that the patient is taking. Also, our patients may not be filling their prescriptions. It's not unusual that patients choose not to fill prescriptions, and so we may be seeing adverse events due to not taking medications. And then certainly there's the phenomena that patients may not take their medications properly because they don't understand the directions. They may be changing the directions due to a misunderstanding, or they may not understand certain effects that they're seeing with the medication that are the intended effects or maybe side effects.
Many patients are on 7, 10, 14 different medications, and there can be interactions among them. Patients commonly have their medications changed when they're hospitalized simply because a hospital cannot have every single drug on its formulary, so hospitals will commonly use a drug that's in the same class but different than the one the patient takes at home. However, if we don't do a good job of communicating that with patients and communicating among the healthcare providers, it's quite possible patients will go home on a medication that is different than the one they take at home, but in the same class, has the same effects, but the patient sees it's got a different name, and so they'll end up taking both of them and can literally overdose if we're not careful about that.
Another factor to be considered in improving understanding of medications is the health literacy of patients.
Patients are very vulnerable when they go home from the hospital. They are going home with an average of 5 prescriptions each. That's a number of medications that they need to be knowledgeable about, need to be knowledgeable not only how to take it, but also about the side effects and the expected effects of those medications. Health literacy plays into this in a very significant way as we're communicating to our patients about how to take their medications. Some of our patients are quite sick and have very complex diseases that really require significant self-management. They're administering their own medications. They're often adjusting their doses according to their responses. They may be measuring their responses to their medications and making adjustments based upon those measurements. And that's fairly complex work to do.
Against this backdrop, experts in care transitions, along with healthcare providers, are continuing to formulate and refine strategies for improving understanding of medications. One recommendation is to start patient education about medications earlier in the care process.
Really, we don't want to begin that education process within an hour of when they go home. It really takes some time for them to absorb this information, and discharge is often a pretty chaotic time. So you really want to start this process a couple of days before their discharge to make them more comfortable with the medications that they'll be taking. You want to also use some established training educational techniques, and there are a few that I can recommend. One is making sure the information is in writing. We all have pretty poor retention, and particularly around discharge, we want to, it's hard to concentrate, and you want to be able to provide some written information that they can refer to at a later period of time.
Another recommendation is to avoid simply lecturing or speaking to a patient and encourage a more interactive process, especially through the teach-back technique.
This is a great opportunity to ask patients to simply say in their own words, what do you know about this medication? How does it help you? The use of teach-back is a particularly effective strategy in this regard, in particular because it attempts to convey information to the patient in a way that's non-shaming and makes them feel as though that they are engaged and they're part of their own process.
Sometimes patients are taking medications that requires them to self-administer, and so it's often a good idea for them to demonstrate to you how they would administer their medications.
Lastly, it's also important to follow up with the patient after discharge. This has been made clear to Dr. Brian Jack through his work on Project Re-Engineered Discharge, an intervention designed to reduce rehospitalizations.
Our 2-day phone call, which is another component of the re-engineered discharge, is done to reinforce the information given at the time of discharge. And it's also a very important part of the re-engineered discharge because we identify things that are off track at this point. And we've identified that half the patients are doing something with their medications that need to be adjusted to get them back on track. Another part of the re-engineered discharge that helps tremendously with people being sure that they take their medications correctly is the after-hospital care plan itself. The after-hospital care plan, when we developed it, I talked to the graphic designers and the health literacy experts and others, and I said, think comic book. So that they, and then we designed this thing that has lots of big fonts and colors and icons and clearly identifies what it is that people are supposed to do when they go home.
And remember, too, that community pharmacists can provide another important resource for patients.
They're the most accessible healthcare provider we have, and they, as we fill prescriptions with our community pharmacies, those community pharmacists have all the information about the medications our patients are taking, and so they can certainly be a professional that will watch to ensure that medications are safely prescribed and that there are no conflicts or interactions between the different medications that our patients are taking. But they can also serve to provide important information, clarification on instructions, and information about side effects or intended effects that the patient may be noting and wondering if it is related to a particular medication.
Perhaps the biggest challenge for healthcare organizations trying to improve medication management is the process of medication reconciliation. Experts generally agree that better medication reconciliation begins with increased responsibility and accountability.
The facilities across the country that are doing a superb job in this area have delineated clear lines of responsibility and accountability among healthcare professionals. There's no ambiguity.
It's also important that that list, particularly the list that the patient goes home with at discharge, is a well-designed list. And specifically, I'd like to see not just a list of the medications that the patient is going to be taking once they get home, but some reconciliation back to the medication list that they came in on, the list of medications and how they were taking it. So we like to provide patients with specific information about medications that they used to be taking but they're no longer going to be taking, or perhaps other medications that they may continue to take but that may change in dose or change in terms of how frequently they take it.
And don't forget that the communication process related to medication reconciliation must include the patient as a collaborator in their care.
If what we're realizing that the patient's going to go home and make decisions, some of them in their best interest and some of them not in their best interest when it comes to their medicines, then we really have to consider this to be a joint process, a collaborative process. And in so doing, we need to create an environment of trust and transparency. In other words, we need to give patients permission to tell us what they're actually taking, rather than starting with us telling them what we think they should take.
And consideration should be given to perhaps bringing in a pharmacist for patients who are on a large number of medications, to have that pharmacist go over all of the instructions and provide a little bit more detail about side effects and expected effects of each of the medications they're taking.
In summary, a recent article in the Journal of Hospital Medicine points out the general principles that organizations should follow when doing medication reconciliation during care transitions.
A lot of this revolves around ensuring it happens at the time of admission, ensuring that it happens at the time of discharge, and making sure the patient is engaged in that process and educated so mistakes aren't made. And it also needs to continue in the home. Because while we're discharging somebody from the hospital and we have this list of medicines, the patient may have multiple bags of other medicines at their home that we're not aware of.
It's encouraging that more and more organizations are making strides in improving medication management as patients transition through their facilities. One of these is Healthy's Care System, based in St. Paul, Minnesota, a large system that includes 3 short-term acute care hospitals and 1 long-term acute care hospital. They have adopted Dr. Coleman's Care Transitions Intervention, which makes use of a transition coach to provide one-on-one assistance and follow-up with patients. As part of their responsibilities, coaches work with patients on their medications.
Typically, we'll do it at the kitchen table, have everything all spread out, have them have their medication list from either the hospital or the rehab unit, and then go through the medications on the list one by one, make sure that they have a bottle that matches exactly for dosages and numbers of times of day that they're supposed to take it, and have them describe to me how they take the medication, when they take it, if they take it with food, if they quit taking it 6 months ago, so that it's their story about the medications that they're taking. If there are any things that are different from the list that they get when they left whatever care center, we coach them to call the doctor.
To have the nurse be able to go into the patient's home and to review the discharge instructions, the discharge orders, medication being key, it has made such a difference for the nurse to be in the patient's home reviewing that information with them.
Certain conditions, such as congestive heart failure, chronic obstructive pulmonary disease, and strokes, and the medications typically used to treat these conditions provide the greatest challenges when managing patients throughout their course of care.
So it's the same diseases that don't have a one-time approach to treatment, but that the patients may need ongoing care. So once we ended up with a list of 11 diseases, then we've looked at where are we taking care of these patients. And by definition, it's not just the short-term acute care hospital, but rather we have to look at information sharing across the continuum, empower the staff members, the physicians, the case managers, the care navigators who are taking care of these patients in the various sites, and not have them start from square one but square 10. The medications also, it's a short list. It's the medications that are used for these chronic conditions. So the patients may be prescribed something in the hospital, and we do our best job with giving them a discharge medication list, empowering them, teaching them. But then they get home and there's a refrigerator with another list, and there's a cupboard full of some more medications there. And so the patient is not a physician or a nurse. And so there's a lot of room for confusion, and that's where the transitions management or the transition coach or the intervention really is most powerful.
This system is also increasing the role of their pharmacist during transitions of care to improve medication management.
What we're doing now is building the pharmacist formally into the discharge process so that they're meeting with the patient regarding their discharge medications. Medication reconciliation for the hospital as a system, and all hospitals really, is a tremendous challenge. But we think formally having the pharmacist talking with the patient as part of that discharge process is a really important part to being successful in that.
Ultimately, the leadership team understands that effective medication management is an ongoing effort, not a quick fix project.
It takes time. It's not something that you're going to be able to do in a 30-day period of time. There's a process that you have to embrace, and it does take time. And if you're tenacious and you stay with it, I believe that you'll see the results both from a process and a quality standpoint, and the patients will be the ones who benefit.
Another organization that is working on medication management is Piedmont Hospital. Located in the Buckhead neighborhood of Atlanta, Piedmont is a Project Boost site, an initiative that provides a toolkit, quality improvement methods, and mentoring to assist organizations with improving transitions of care. Piedmont's approach to medication management during care transitions begins with a focus on the patient.
We try to look at the patient and see how they best understand what's communicated to them. Do they do better with printed out material that they can take home and read at their leisure, or take and read while they're here? Do they do best if you call a family member and talk to them so they understand what's going on, because the patient just really can't cope with it?
One project that the hospital recently undertook to improve medication use started with an exhaustive review of the types of conditions that caused their greatest number of readmissions.
We actually pulled the roster of all of our admissions and discharges and readmissions over the last 2 years, and this was difficult because it had to be manually done. And looked at the reasons for admission, their comorbid conditions, etc. And we came up with certain triggers that we look at, and that is particular disease states like COPD, chronic respiratory failure, chronic renal failure, diabetes, congestive heart failure. So our concentration is immediately peaked with those particular disease states. They're chronic, they're lifelong, and they're prone to exacerbations.
For these higher risk patients, extensive education takes place regarding their medications.
We utilize a lot of nursing counseling, and pharmacists can come in also and talk to the patients as they're being discharged. And each medication is gone over, and any changes made to their medication regimens are gone over.
We have liaisoned with our medical library that they will print any information necessary for those disease processes in layman's terms and hand deliver it to the patient so they have a literary backup. Of course, if they can read, and if they can't, then we provide some other means to help them with that. And then we also have pathways that our home health providers have developed for these patients, so that if we diagnose congestive heart failure and we have signs and symptoms they need to recognize and be wary of, then the home health provider is going to support that in the home as well.
Any changes to the medication regimens are also communicated to their home physician, their primary care doctors, so they're aware of these changes that have been made while the patient's been hospitalized. So it really helps to continue that care as they go home, so the person who will next be helping to take care of them knows about the changes.
For certain patient populations, the hospital also uses technology as appropriate to help them manage their medications.
There are services that will send reminders to your cell phones or page you to remind you to take your pills that we sometimes utilize with some of our younger patients. They'll get a text message to remind them to take their medicine, and that's worked well for some of our patients.
Clearly, each improvement effort that is made with medication management is grounded in making patients feel safe and in control.
It is paramount to the patient and the family to make sure that when we tell them they're ready to go home, that they feel that they're ready to go home, and when they get there, they're safe. They're well taken care of, they feel knowledgeable about what has happened to them, and they feel like they're in control, and they have something to say about it.
In this program, we have offered strategies and suggestions for improving patient understanding of medications. Along with the information that you've already gained, you may want to consider the following questions in starting to further your knowledge of this area. When does your organization start patient education on medications? Is it before discharge? How can you increase the use of the teach-back technique? Does your organization follow up with patients at 48 to 72 hours post-discharge to confirm prescriptions were filled and to answer questions? And how can you position your community pharmacist to be successful in helping patients? Managing medications is an important but sometimes challenging aspect of the transition of care process. Improved understanding of medications, however, is a very worthwhile endeavor, as it's an important ingredient in the recipe for improving and maintaining your patient's health.